Right back at you. I appreciate the opportunity to be with you all here today. Are you able to see my slides? So my talk is entitled Assessment for Learning at UCSF, Lessons from a Change to Pass-Fail Grading. I too wish that I were there in person with all of you, but instead I'm here in San Francisco at 9 in the morning. I live north of San Francisco in Marin County near the famous Muir Woods with the beautiful redwoods. And my commute, which I don't do as frequently these days, is across the Golden Gate Bridge to UCSF. I'll begin this talk by asking you to imagine a world where every medical student and resident would be less focused on performance and competition and more focused on their learning and improvement of their practice. This is assessment for learning. And this is not what our students typically experience in their core clerkships. Core clerkship grading leads students to feel the brunt of the pressure to perform and to look good for their supervisors. In contrast, we are aiming to shift toward assessment for learning at UCSF. With assessment for learning, each student on these ladders is prioritizing the steps they need to take to get to the next rung of the ladder of improvement, rather than racing to get ahead of the student next to them. We believe that our faculty and our resident teachers want to help students with assessment for learning, and they need the tools and the structure to be able to do that within an assessment system that prioritizes our students' learning. The way we deliver medical care has changed over the past century, but unfortunately, the way that we assess and grade medical students really hasn't. In the past, the physician was characterized as the hero physician, as shown on the left of the slide, usually a white man with all the knowledge he needed in his head and a few tools in his bag. In contrast, the modern physician needs to be skilled at teamwork, working with diverse interprofessional colleagues in service to our patients, using a range of competencies and skills to help our patients through challenging illness situations. Clerkship grading reinforces many of the characteristics of the 20th century hero physician: individual accomplishment rather than focus on teamwork, and medical knowledge rather than focusing on a range of competencies. Today, I will share with you our efforts at UCSF to shift our focus for assessment of clerkship students toward assessment for learning. I'll share with you the rationale for our change and how this really represented a culture change. I'll also discuss how we provide opportunities for our students to differentiate themselves in the residency match. And then I'll share how we've evaluated and reflected upon this ongoing change. This is a one-slide depiction of our current UCSF medical school curriculum. Our Bridges curriculum launched in 2016. It has 3 phases: Foundations 1, the pre-clerkship phase, which is a 1.5 years, followed by Foundations 2, the core clerkships, which start in January of the 2nd year. With this new curriculum, we move step 1 to be positioned after the core clerkships. And then in March of the 3rd year, students begin career launch, which is an expanded 4th year. One of the motivators for us to consider moving to pass-fail grading in the core clerkships is that with the earlier start to Foundations 2, our students are starting their core clerkships in January of their 2nd year. And we felt that it was fundamentally unfair to assign these very high stakes grades that could make or break their chances of a residency match before they were even halfway through medical school. We observed many other challenges with clerkship grading that predated our Bridges curriculum. I recall as a student at UCSF myself that I and my colleagues had a lot of concerns about the fairness of clerkship grading, and these concerns have only heightened over time. I'm sure you've heard questions from students about who evaluated them, who didn't evaluate them, why attendings and residents were rating skills like physical exam that they had never observed, why the transparency of clerkship grading seemed to be lacking, and the concern that very small differences in scores, tenths or hundredths of a point, leading to honors versus pass grades. If only this one evaluator scored me a little differently, I would have earned honors. Other concerns about clerkship grading that were very important in our decision making around the change that we made addressed equity, students' approach to their learning, and students' well-being. And I'll describe those more here. As we were trying to understand why our students felt that our clerkship grading system was so unfair, we undertook a survey study at 6 medical schools in the Western United States. And on this survey, we included fourth-year medical students who had just finished their core clerkships and received their grades. One section of the survey asked students the following: on a scale of 0 to 10, based on your experience, how important is each of the following in determining your final clerkship grade? And I'll ask you to think to yourself, which do you think of the items on this list students rated the highest? Students across the 6 schools felt that being liked, the particular attendings you worked with, and the residents you worked with were the main drivers of their clerkship grades. And this is really important in understanding our students' objections to the way that grades are assigned. These items are out of their control and mean that whatever effort or learning strategies they use, those won't change the fundamental facts that if they're not liked or they don't work with the right people, they might be out of the running for top grades. At the bottom of the list were things that we might think would be most important to being an outstanding physician: your rapport with patients and families, or your improvement over the course of the rotation. We also notice with these ratings that the items at the top of the list are particular concerns around bias. Teams might be more predisposed to like certain students who are more like them and leave other students at risk of lower clerkship ratings and grades. In the same study, we looked at the relationship between students' perceptions about grading and the number of honors or top grades that they earned at the 6 schools. And in a multivariate analysis, we saw, not surprisingly, that students applying into more competitive specialties had more clerkship honors. And among the students who had more honors, those were the people who thought that who perceived that the accuracy of grading was higher. So if it works for you, if you're successful, then you think it was an accurate system. We were interested to look at student demographic factors in relation to honors or top grades earned. And we found when we put these multiple variables into our analysis, the demographic factors fell out. And the factor that was associated with numbers of honors earned was stereotype threat. And this seems like an important opportunity for intervention. Stereotype threat is the phenomenon in which a member of a group with an associated stereotype is then subject to believing that that stereotype is true and suffering worse performance. This was originally described in examinations of math. If you have men and women take a math test, they will score the same. If you then, before men and women take a math test, tell the women that women tend to score lower on that math test, the women will indeed fulfill that expectation to score lower on the math test. Stereotype threat is relevant to the medical environment, particularly for students from backgrounds underrepresented in medicine, where they will hear from their friends, from social media, that students from their demographic groups do less well in clerkships, and that itself can lead them to perform less well. A final point I want to make from this survey study is that across the 6 schools, the findings were very similar. So public and private institutions with slightly different grading schemes had the same findings. And this led us to conclude that the answer to the problems with clerkship grading is not to add a high pass option or change to letter grades or make small tweaks to the system. Something larger is needed. We have worked on UCSF's clerkship grading problems for a long time. Some people say, how did you make such a sudden decision? And the answer is that it wasn't really sudden at all. It represented a lot of work over at least 5 years. We tried increasing our cap on honors from our restrictive cap of 25% up to 45%, which I believe might be closer to where you all are. And things got worse. Students felt more upset if they were in what they perceived to be now the bottom half of the class. We added core clerkship grading committees, which I think were somewhat helpful. The faculty and the students perceived that this was better in terms of standardizing the approach and the consistency of grading across our multiple sites. But it didn't really address the issue of perceptions of grading on fairness, equity, and well-being. We eliminated the threshold medical knowledge exam score, meaning that we used to say, well, if you don't get a score of whatever, 75 on the exam, you're ineligible for honors. And that led students to feel that even if the exam was weighted at a lower percentage contributing to the grade, it was really all or nothing. And we've had multiple initiatives to improve the quality of summary evaluations. So transparency guidelines to make it clearer to students, changing our form, looking at the amount of contact evaluators had. And really with all these interventions since 2014, our students' stress and dissatisfaction with clerkship grading increased. I think that was in large part due to the rising numbers of applications to programs in the match. So really feeding on the national stress about the transition from med school to residency. So in 2019, we eliminated clerkship honors grades, changed things to pass, fail, and committed to assessment for learning. We increased focus on direct observation and feedback, and made the difficult and debatable decision to keep honors grades in the 4th year. This was in service to the fact that our students do need to go through the match. We felt that if they all had a year of learning in the core clerkships, that would help with the inequities that arise when students who come from a more privileged background or who've worked in healthcare hit the ground running and earn more honors in 3rd year. We thought, well, we'll give everyone a year of learning and then they'll all be prepared to be successful in 4th year and to be in an honors graded environment. And we continue to work on the quality of our narrative evaluations and to address inequity. Those are both works in progress. I would say that a major catalyst that really galvanized our community around the change in clerkship grading was the discussion of the inequity in our clerkship grading process. This began when one of our students said that he observed that the students selected for AOA appeared to be less diverse than our class as a whole. We took that feedback to heart and undertook an analysis of our own data, which showed that using our clerkship evaluation scores across all 8 of our core clerkships, the students from backgrounds underrepresented in medicine over 4 years were scored about 1/10 of a point lower on our scale. This 1/10 of a point difference for UIM students, which was statistically significant in all 8 core clerkships, led to those students being about half as likely to earn clerkship honors and about 1/3 as likely to be selected for AOA. So we called this the amplification cascade, where very small differences in assessed performance that are unlikely to be educationally or clinically meaningful lead to large differences in honors and awards that then determine your competitiveness for a certain residency or a certain specialty. So this was a very important finding for us, and other schools have published similar findings, including University of Washington, Washington University, and St. Louis. So an important catalyst for us to make a change. We then looked at why the small difference in assessed performance might exist. We undertook a root cause analysis using a fishbone or cause and effect diagram as shown here. So the head of the fish captures the problem: fewer honors grades and awards for UIM students. We identified factors related to the students themselves, the faculty and resident supervisors, the learning environment, the school policies that would affect all students' chances of earning honors. And in addition, we identified a collection of other factors, and I'm only showing some of them here, that would disproportionately affect UIM students: stereotype threat, the unconscious bias of their supervisors, healthcare inequities that they observe and try to address in the clinical environment. So we feel that UIM students are disproportionately burdened with these additional contributors to the challenging situation of trying to earn clerkship honors and AOA. And as a result, we changed our clerkship grading system, and we recently made the decision that I know you all made to cease our membership in AOA. In another study, we looked at how UIM students and residents would define equity in assessment. I spent a lot of this talk describing problems with the way that we assess and grade learners. What if we take a different approach? And in this study, we used a framework called the anti-deficit lens to think about what are the success factors in the process of assessing UIM learners in the clinical environment. So we interviewed about 20 students and residents from UIM backgrounds and asked them, what would equity in assessment look like, and how can an assessment system best capture your achievements? And their responses fell into two broad buckets. The first bucket we called sound assessments that capture achievements. So this bucket means all the things that good assessment should do for all of our learners. Frequent observations with real-time feedback against predefined expectations. So the students and residents were saying, move away from such a focus on knowledge and exams and just oral presentations, and look more at what we're actually doing with our patients and team members. And when they described situations in which the assessment system seemed to work well, they often described contexts where they had supportive longitudinal relationships with their supervisors, which is, of course, super hard in our current clinical environment. And in general, the participants felt that all of this was more likely to occur in residency than in a medical school where students are graded and are lowest on the hierarchy. Our participants also focused in on practices that they felt would support equitable assessment. They emphasized the need to avoid comparison to peers. They described how evaluators often seem to assess them in comparison to the other student on the team or the last student that they worked with, rather than by comparing the student to the expectations or to how the student was performing last week or last month. Our respondents felt that narrative assessment was important so that they didn't just become a number on a scale, but rather that someone would describe their contributions with patience. They emphasized the importance of training supervisors to avoid bias and helping our supervisors become comfortable asking about and acknowledging learners' identities. They noticed that supervisors sometimes seemed uncomfortable with that aspect of their relationship with their learner. Our change in approach to assessment with emphasis on assessment for learning was and is an ongoing culture change, and it's certainly not over at UCSF. We have educated our community about assessment for learning. Assessment for learning has been defined by Schuworth and van der Vleuten as an information-rich approach where you collect and combine a lot of information from various sources to inform about the strengths and weaknesses of each individual student with the purpose to optimize their learning. So assessment for learning helps people learn while they're still learning, not after they finish the learning. The central goal is not whether John is better than Jill or better than a cut score, but to determine whether John is maximally better today than he was yesterday, or whether Jill will be maximally better tomorrow than she is today. To help us with this culture change, we engaged Kees van der Vleuten, who is an expert educator from the Netherlands. We applied for and were fortunate to receive a Presidential Chair Award, which is a UCSF award for a visiting scholar. And this was the first Presidential Chair Award at UCSF for an educator. So that was exciting. And he, with this award, visited UCSF several times over more than a year to help us educate our faculty and educate ourselves about how to change our culture and how to use work-based assessment and move toward programmatic assessment. His observation of our culture is that it was very much a summative assessment culture where people perceived assessment as very high stakes. And he made that observation about us at UCSF where he was visiting, but I think it really reflects a national difference between the United States and the Netherlands. In the Netherlands, somehow their residency match is not overly high stakes, and people are able to go through that process in a much more low stress way than they do here. To make this culture change, we were attentive to the leaders in our departments. My boss and the Vice Dean for Education, Catherine Lucy, and I met with the education teams in each department that hosts clinical students. So the education teams that we met with included the chair, the vice chair for education, the residency program director, and the clerkship director meeting with us. And I think it was powerful to have that whole team in the same room and think about how we're all working toward a common goal rather than an us versus them. We discussed our vision of promoting a culture change toward assessment for learning and encouraging a growth mindset among our students, residents, and faculty. We discussed our strategy of promoting observation and feedback and having our teachers serve more in a coach role. We also worked on and continue to work on the importance of timely evaluation data. It really doesn't help a student to get an evaluation back when they're all the way through the next rotation and then discover that somebody thought they should have been doing something differently in the last rotation. And we asked them to partner with us on motivating this culture change, partnering with us. And we also tried to emphasize success factors. So rather than just hounding our late evaluators with more email reminders, also thinking about how we could reward the people who do assessment, feedback, and written evaluation well. This culture change represents a shift in the role of our frontline teaching faculty and residents. In the old model, from an assessment perspective, the supervising resident or attending watches the student perform for however long they're on service, completes written evaluation after the student leaves the clerkship, and then probably has to defend those scores and comments when the student complains that things don't seem fair. In our new model, the role of the frontline teacher is to observe and coach the student. We're asking them to provide frequent feedback and giving them a tool with which to do that. Without grades, we find that students are more willing to ask questions, and we ask our frontline teachers to invite those questions and then complete timely evaluations at the end of the time working together. So our approach now to assigning clerkship grades, which I think is still in process, really begins with our focus on feedback. We're using a work-based assessment tool so that students receive real-time feedback and coaching from their teachers. The faculty and residents complete summary evaluations, and with our change in grading, we decided that interns would no longer complete summary evaluations so that they could focus on the feedback and coaching in a way that would feel comfortable to the students and also offload some of their work as busy interns. We use the NBME subject exams, and then a grading committee reviews the evaluations and summary statements to assign a grade. Our grading committees are comprised of the site directors and clerkship directors, so they work individually to draft those materials and then come together to make final decisions. Our efforts to improve our culture of feedback are shown here. This is our infographic that we've distributed across our clinical sites that shows our educators that feedback is part of a cycle of continuous improvement. We ask our teachers to observe their students and then to give feedback that discusses what the students should keep doing, what they're doing right, what they should stop doing, and what they might want to start doing, something new that they could add. And if possible, the feedback giver should observe the student again and continue the cycle to help the students see where they've improved and what they need to do next. Overall, this change has gone well, and I would say particularly residents have really identified with this change, and we often hear comments from residents that they wish that they had had this type of experience when they were students. So the culture change was more readily adopted by residents than faculty. Our work-based assessment tool is called the Bridges Brief Observation Tool, so people refer to it as the BBOT. We originally tried this in MedHub, and that didn't work so well. MedHub was supposed to have an app on the phone that didn't really work. And so there was a hassle factor that you had to go back to your desktop to fill it out. And some people also confused it with a summary evaluation. So we switched to using QR codes that you can scan. So each student has a QR code on their badge. The student or the resident or the faculty can scan the QR code, pull up a Qualtrics survey, and then fill out their feedback for the student, which then goes into the student's dashboard so that they can review it over time and look at it with their coach. In our first year using the less desirable method with MedHub, we collected 7,000 BBOTs for our students. So the amount of feedback definitely improved, and it improved in areas where we had traditionally struggled, like direct observation of the student doing a history or physical exam. The evaluators can also give feedback on written notes, oral presentations, or over time, we've expanded the categories to include procedures and communication skills with patients or family members. With this tool, we continue to promote a change in mindset from a fixed mindset to a growth mindset, with a grading model that encourages a fixed mindset where students want to play to their strengths and show those off and relegate their areas of weakness to things that they just can't work on because it might hurt their grade. And that in turn promotes the mindset that I'll just never be good at this certain skill or this certain knowledge. In contrast with a growth mindset, the learner would believe that with the right effort, with the right coaching and practice, they will be able to succeed regardless of whether they identify a certain area as a strength or a relative weakness for them. I've mentioned that we use clerkship grading committees, and this is something that we continue to develop. A group process for any high stakes decision in general is better than an individual, like a site director or clerkship director making a judgment alone. With a group, you have the opportunity to bring in diverse people, diverse perspectives, and more perspectives. We ask our grading committees to synthesize data from the variety of sources, the way that a clinical competency committee would, and to think about how they can move away from focusing just on the students with problems to more of a developmental model for all students. In order to try to shift our culture toward genuine comfort with discussing feedback between students and supervisors, we've asked our clerkship grading committees not to use the BBOT feedback in making grading decisions. That is just for the students learning, and then the summary evaluations in the exam contribute to the grade. We try to offer our students opportunities to differentiate themselves in residency selection, and we will hear how that goes as we move forward with this year's match. As I mentioned, we made the decision to keep honors grades in the 4th year. We consulted with other schools like you're doing and thinking about a change in grading. And I recall that 2 schools that we spoke with did not use honors in 4th year and felt that that worked well for them. But in our environment, speaking with our departments, speaking with our program directors, we decided that we would keep 4th year honors in service to the residency match. And we felt that the departments would work with us to take some ownership over seeing students in those 4th year sub-Is, describing that performance and providing information that would be most useful to their colleagues in that specialty about students' readiness for residency programs. We've worked with our departments to encourage standardized department letters. Some departments have a robust system to do that, like our departments of emergency medicine and medicine, and others are just beginning to think about adding department letters. Our students all do a required research project, and like at other schools, they have many extracurriculars. So I think this is a work in progress. Some people need to think about that there are more pieces of information in the application than just clerkship grades. But this also feels like a threat in the context of step 1 also moving to pass-fail next year. As we have these discussions, we reinforce with our program directors that clerkship grades, while useful in the residency match, really reinforce characteristics of an old model or an outdated model of assessment. In older models of assessment, the purpose of assessment was viewed as classifying or ranking people, with the assumption that some learners are just better and more capable and others might need to be left behind. This all reinforces a fixed mindset. In contrast, with a mastery model, the assumption and the purpose of assessment is to promote learning because all learners have the capacity to learn and grow. And I think you can easily see that students who've made it into medical school all have the capacity for success. To achieve what we need them to achieve in terms of competencies, they need frequent and immediate feedback in the clinical real-world context. We continue to evaluate how our new system is working. And with these photos on the bottom, I want to emphasize the importance and the rich contributions that our students make toward assessing our programs. These are all learners who've participated in the research projects that I've been citing here. 2 of them on the left are now residents. But they really help us see this program from the lens of a critical stakeholder. I mentioned the survey that we did at 6 medical schools about student perceptions of the fairness and accuracy of clerkship grading. We repeated that study at UCSF after we changed our grading structure, and the results are shown here. We saw improvements in students' perceptions of the fairness and transparency of grading, the usefulness of feedback, and the perceptions that resident evaluation procedures were fair. You can see that these weren't ringing endorsements. Students weren't rating these at a 5 level. And I think to some degree, the culture change takes time. We also used validated scales to look at the clerkship learning environment from the perspective of mastery versus performance orientation. And that's where we also saw some big changes. In a mastery-oriented environment, students believe that the messages they're receiving are that they're learning for the sake of learning. And we were glad to see that improvement. In a performance-oriented learning environment, students believe that their primary job, as told to them through the messages in the environment, is to perform and look good and make mistakes. And they saw a decrease in that type of messaging in the environment after our grading change. We did not see changes in perceptions of evaluation bias or evaluation accuracy. I still think we have work to do despite our efforts with feedback to improve the attending's ability to have time and skill to observe students and construct meaningful feedback. So that's an area of continued growth for us. In a qualitative study, we interviewed students about the perceptions of this change. The participants in this study were students who went through the clerkships after the change and some students who straddled both systems at UCSF. They felt after the change that the environment gave them a much greater sense of agency over their own learning. And the students who had only experienced the environment with no grades thought a lot about what it would have been like with grades and felt largely relief that they were not in a graded system. They felt that the absence of grades allowed them to set their own learning priorities, to think about what competencies do I need to work on, and then make choices like, well, today I'm going to practice a procedure, today I'm going to study for the test, without the parallel thought of what will my team think about that choice. They felt much more able to receive feedback, including constructive feedback, or to ask for it without a feeling that that could reveal a weakness and damage their grade. Regarding learning risks, they talked about asking questions that they genuinely wanted to know the answer to, instead of feeling that they needed to ask questions that would somehow make them look smart or that they already knew the answer to. And they had some interesting comments about how they were able to communicate with the team. They felt more able to offer different opinions, to maybe add something about the patient that others hadn't discussed in relation to social life or patient backgrounds, or even to disagree with the team without worrying about how that would look, but rather with a thought of how that might help the patient's care. And really, regardless of what question we asked, the student responses frequently addressed their own well-being. They felt that the environment was lower stress and led to their better ability to attend to their physical health and the balance of personal life with clerkship duties. The authenticity theme was very interesting. By that, the students were saying that they felt more able to be their authentic self. They still recognized that they were in a hierarchy in which they were at the bottom, but they felt more able to relate to the team as another human being, as another care provider, and not just as the student trying to curry favor that could improve their grades. One student said, "I heard that this was the worst year of med school, and I'm not feeling that at all. I'm tired, but not overly stressed. I'm appropriately challenged, and I'm excited to show up and learn every day."
Wow.
And another student said, "I can develop as a medical student and in a more natural setting, in a way that feels a little bit more like I'm in my skin when I'm in my learning environment, as opposed to having to put on a face or change my personality." We have also asked our faculty about this change, and the study that I'm showing here comes from interviews with faculty in the departments of medicine and surgery. We felt that those two departments, being large departments with different cultures and different clinical focus, would be a nice way to capture the range in how faculty are thinking about this change. And their comments fell into three areas as shown here. They first thought about the impact of this change in assessment and grading on themselves as faculty. And in that area, they expressed curiosity and interest. They also expressed some worry. They felt very familiar with the old system, very comfortable with it. Some of them acknowledged that as faculty members, kind of by definition, they had had some success in the old system, and that now they needed to learn some new skills. Their perceptions of the effects on the change on students were neutral to positive. We heard comments that they no longer needed to wait for grade appeals or hear comments from students trying to couch a question of what can I do to earn honors from you. They were worried that the change in grading might reduce student motivation, but none of them were able to think of a specific example where a student actually had seemed less motivated because of this grading change. They did worry with students that they might be missing out on necessary stress. Some of them commented that physician practice is hard. If you haven't gone through the stress of a graded clerkship environment, you might be less prepared for the realities of residency or the realities of physician practice. Others wondered, well, that may be true, but maybe it's us who need to change, not the students in that regard. They expressed awareness that there seems to be a systemic culture change, and that led to the title of our article. There's a lot of change afoot, and they wondered to what degree we were positioning ourselves as an institution to be part of that change or at the forefront of that change, versus to what degree we might be exposing ourselves to risk if we make a change that is not well received. And I would agree with those comments that that remains to be determined. Faculty made comments about their ability, or faculty ability in general, to reliably identify the best or the top students. Many of the comments reflected this part of our culture where we believe it's important to know the top 5%, the top 1%, and to call that out. One faculty said, for a lot of students, grades are based on how much they're liked. And from my personal experience, both when I was a student and now from the other side, I think it's easier to like someone or think favorably of someone who reminds you of yourself. However, I also believe that when I give out grades, there's a large degree of objectivity, even if there is some bias in there. So this person believes they're somehow able to rise above the tendency to like people who are like us. Another quote says, every attending you ask, they'll say, I can tell who's the good student, who's going to do great, but I doubt that's really true. So in conclusion, I have a couple of slides thinking about how to consider this problem in terms of the national larger context. Clerkship grading fits the definition of a wicked problem. Wicked problems are large, complex, social or societal problems that defy easy solutions. As they say, if there were an easy answer to all of this, someone would have already thought of it. With wicked problems, there are multiple pieces that are interconnected, multiple stakeholders with conflicting agendas. Every solution affects other parts of the system. So there's not really one answer, but rather better and worse interventions that need to be evaluated and then modified in more of a continuous cyclic process. Clerkship grading, step scores, metrics, holistic admission, all of these topics are part of an active national dialogue. And as we undertook a change at UCSF, we have tried to stay abreast of this national dialogue and contribute to it. The INCUS conference was the invitational conference on USMLE scoring that led to the upcoming change to pass-fail step 1 scoring. The AAMC is making lots of resources available to try to help students target their residency applications in a more rational way. And the Coalition for Physician Accountability is a group of organizations working on changing the transition process, or the match, from undergraduate to graduate medical education. And I am fortunate to be working with that group as part of a large team of student and residency educators and public stakeholders to think about how might we change the system in a way that would help students get to optimize residency matches and also have a better learning experience in medical school and residency. There's also been attention to the large burden on faculty of this whole process and how we might improve the experience of faculty as well. I'll conclude with a quote about equity in assessment from a paper that was part of the compendium from the Macy Foundation Conference on addressing harmful bias and eliminating discrimination in health professions learning environments. Equity in assessment, which I think is a beautiful vision for all of us, entails all learners having a fair and impartial opportunities to learn, be coached and receive feedback, be assessed and graded, be advanced and graduated, and be selected for subsequent training and job opportunities. In summary, we remain focused at UCSF on assessment for learning, where every student has the opportunity to learn and become an outstanding physician through individualized, holistic assessment. Some of the lessons learned that I've addressed today are: listen to your students. They've been asking for us to fix this problem for a long time. It's critical to continue to examine your own data. You don't know what you don't look for. Expect tensions. There's no one solution that solves all problems, and plan how to manage them. Partner with departments and leaders across the institution, and think of assessment as a system. And with that, I will stop and be happy to take any questions. Thank you all very much.
Thank you so much, Karen, for that incredible talk. I know there's going to be a lot of questions, and so I would just ask if you could raise your hand on the screen so that I can see you, and then call upon you to ask Dr. Hauer questions that you might have. I'm going to try and stay away from using the questions on the chat function, but just raise your hand. Okay, let's go with Chris and then David Thatcher. So Chris, go ahead.
Hi, I'm Chris Strother. I'm in the Pediatric Emergency Department. Thank you so much. What a lot of wonderful information in that talk. Thank you. Can you talk just a short bit about the BBOT versus the, we're talking about expanding the use of the SDOT in the ER for our residents. And it sounds like if there's a briefer version of that might be really useful. Was that a very intentional choice? And I'm really interested to hear more about the QR code. Like, what a great mechanism.
So the BBOT is a local tool, and it is a work-based assessment tool. We really struggled with how to keep it short and also useful. So there's a space to indicate the evaluator's email, and then the comments get sent to the evaluator for a passive sign-off, meaning they receive them, and if they don't think it's true or not what they said, then they could speak up, but otherwise there's nothing they need to do. We asked them what they observed from a drop-down list, so history or physical or communication or procedures. We do have an entrustment rating using the Ottawa scale, and I think that's an area that we're still wrestling with because it's so hard to do faculty development with all evaluators about that a lot of them don't really know what it means. And then they write comments. And so we've, to get this going and to launch it, we have focused on their job to write a meaningful behavior-based comment. And they typically do. You see some differences, some are short, some are more elaborated. We noticed with the QR codes that they were much more likely to write what you might consider to be a true feedback comment. When we were using MedHub, they kind of wrote often more what would look like an end of month global summary. And I'm happy to hear from you offline about the QR code if you want to hear how that works, but that's been a game changer. People really like it. It's kind of cool, and it also is very efficient.
Thank you, Karen. David Satcher, go ahead.
Thank you so much for a really illuminating perspective. Among many high school students, a very pervasive concern is often which college they're going to get into. And in pre-med college students, it's about what medical school they'll get into. And among medical students, it's which residency are they going to get into. Have you found that your culture changed, that the new model shows any change in students' anxiety or concern about what kind of residency they're going to get into?
The answer is I don't know. They've been very stressed this year, and I think COVID complicates the whole thing because there's a whole new reason to be stressed about the whole process. There was a flurry of stress at the beginning of fourth year with people who had chosen fourth year rotations that were pass fail, wanting to switch to rotations that would give them an honors grade if they could earn it. So that was new, and I think that'll be a temporary flurry. What I can say now is they have gotten a lot of interviews, so the stress has calmed down now that they've realized, yes, they are going to get interviews. But we really need to evaluate that longer term and see.
Other questions? Nisha, go ahead.
Hi, thank you so much for your talk. It was really informative, and as someone who is a big fan of coaching and growth mindset, it was amazing to see how you have implemented that. My question is sort of related to the faculty side. I think with the change to pass-fail for USMLE, and now with some schools changing to your grading system, did you encounter any takeaways in your culture change that could be used to guide faculty in how to more holistically review applications and really sort of respect this change rather than, you know, perhaps relying on the rest of the metrics that still exist? And I think the challenge for me is I'm an ophthalmologist, and sometimes we don't have the MSPE even with the early match. And so I think it's refreshing that step one is going to go pass fail, but I'm just sort of challenged with how do I really approach the review holistically, particularly when some schools still have grades offered.
It is hard. At our school, there was the statement to our residency programs that they should make efforts to diversify. And many departments were successful by recruiting new people to help in residency selection. You know, it's always hard to get people to do that, but when the ask was around equity and diversity, new people came to the table and said, yes, we are willing to participate. And so some departments had either a parallel committee or a pre-committee or some process to do some version of holistic review by looking at applicants differently and then working with the usual committee. So I think that that is one important motivator to get people to think differently when sometimes they might have had a fixed belief like, well, we'll never have time to read all that information, or we'll never have time to stop screening with step one. And then seeing when the residents arrive that they're excellent residents provides motivation for the next year.
Thank you.
Other questions? You've left us with a lot to think about, Karen.
Well,
And-
thank
and-
you.
and-
And thank you all for your great attention and questions. I really appreciate it.
So I've put a bunch of the citations that Karen talked about during her talk in the chat function. We could send those out if people find them useful to look at. The work is really incredibly well designed, incredibly meaningful to look at, and thought-provoking in so many ways. And so before we let you go, Karen, I want to really personally thank you for not only speaking to us today, but I think for the work that you have contributed in this area that is really remarkably important and serves as a guiding post for many schools around the country, and for your commitment to tackling what you have called wicked problems like this. So with real tremendous gratitude, and I hope we can welcome you here in person one day for much more time. So thank you for joining us. Just a reminder to everyone to please complete your evaluation. Olga has placed the link in your chat function, and to remind you that we will get back together after the holiday season on the 13th of the coming year for our Education Research Day Blue Ribbon winners who will be presenting. So please do come join us then. And Karen, thank you so much.
Thank you all.